Hi everyone and welcome for this case number 5 of the liver pathology slide review. Remember that you can access the whole slide images, you have the details here. So this case was a biopsy of a nodule that was discovered in a patient that was undergoing surveillance after a surgical resection of a colorectal cancer. And the question was, is it a liver metastasis? So let's look at the slide. So this is the biopsy from the nodule. You have here briefly a tumor that is composed of hepatocellular nodules. They look blonde without atypia. You have some steatosis. You also have some fibrous tract which contains ductular reaction, inflammatory infiltrates. The appearance is quite the same throughout the whole sample. Here you have a dystrophic vessel within a fibrotic tract, inflammatory infiltrate, ductular reaction, and these hepatocellular nodules that are surrounded by fibrosis. And the biopsy, the appearance is quite the same throughout all the fragments. Again here, fibrous tracts with a dystrophic vessel, hepatocellular nodule. So when you have this appearance, there are several differential diagnoses that you may consider. So it looked like cirrhosis, so it may be cirrhotic tissue. You know you're in a nodule, but you know it can be a sampling error, and you have the non-tumor liver, because really this could be cirrhotic tissue. The lesion appears to be hepatocytic, so it could be a benign tumor, a focal nodular hyperplasia, or hepatocellular adenoma, or it could be a malignant tumor, hepatocellular carcinoma. For hepatocellular carcinoma, you have absolutely no atypia. The hepatocytes look really normal, with no increase in nuclear size, in cellular density, no pseudoglandular formations, and so on. So it really does not look like an hepatocellular carcinoma. And for the benign tumors, the two main hypotheses are focal nodular hyperplasia, hepatocellular adenoma. So it can be difficult to differentiate these two benign tumors sometimes. Here, the features that are suggestive of a focal nodular hyperplasia is this nodular architecture, the big fibrotic tracts, the dystrophic vessels, ductular reaction, and again this nodular architecture. So this type of appearance may also be observed in inflammatory infiltrates, adenomas. So diagnosis may be difficult within FNH, focal nodular hyperplasia, and this particular subtype of hepatocellular adenoma. And the thing that you have to do to have a firm diagnosis is to perform immunohistochemistry. So you can perform CRP staining for inflammatory adenomas, but remember that some FNH may express CRP. But the main antibody that will help you is glutamine synthetase, because it will be expressed at really low levels in inflammatory adenomas. It can be expressed in adenomas that are inflammatory and also beta-catenin mutated. In this case, you have a diffuse staining. And for FNH, you have a really typical staining, which is called map-like staining, with regions that are densely positive and regions that are negative or very weak adjacent. So this is the main immunohistochemistry you will have to order. And also you can order some glypican-free if you want to rule out an hepatocellular carcinoma, but remember that approximately half of hepatocellular carcinoma are glypican negative. So the main tool is now the glutamine synthetase staining, so we will have a look at it. So let's look at the glutamine synthetase staining. And you can make the diagnosis at low magnification, and you have here what I called MAP-like staining and what is called MAP-lab staining, with these really strongly positive areas and adjacent to these areas some negative areas. So let's have a closer look. You have here the fibrous tract, you have some hepatocytes here that are completely negative or only show a weak staining, and adjacent to these hepatocytes you have other ones that strongly express glutamine synthetase. So this is really a typical IHC staining that allows you to perform the diagnosis of focal nodular hyperplasia. So this is good news for the patient. It's not a metastasis, and you can even with only this marker make this diagnosis with the morphological appearance that is benign, the fibrous tracts, the dystrophic arteries, the inflammatory infiltrates, the ductular reaction, and most importantly this kind of GS staining. You can make a final diagnosis of FNH. Focal nodular hyperplasia, the final diagnosis, and we will now review the main learning points from this case. So the diagnosis of focal nodular hyperplasia is usually performed by imaging, and it is a frequent lesions. And the focal nodular hyperplasias are biopsied when they are atypical on imaging. And from the pathological point of view, you have to remember that it looks like cirrhotic tissue with these hepatocellular nodules, the fibrotic bands, and also ductular reaction, inflammatory infiltrates. The key point for the diagnosis is the GS staining with this MAP-like staining that you don't see in other tumors or other diseases. And the main differentials are hepatocellular adenoma, mainly the inflammatory subtype. The GS staining will allow you to make the difference, and also cirrhotic tissue, because cirrhotic tissue can really resemble to focal nodular hyperplasia, so you have to keep that in mind in your differential diagnosis. So that's the main differential if there is no atypia. So it was an important case because these biopsies are not so rare, and you have to really know well this entity, as the implications are really important. Thank you.